Good afternoon. Some people know me well and I heard good afternoon. Others don't know me well and they said good afternoon. So good afternoon. Oh, thank you very much for that. I want to thank you for joining us for this 2025-2026 Alvin F. Poussaint visiting lecture, both online and here in the Waterhouse Room, online and in person. And I just want to go over some very quick things before we really get started with it. Since this is also on Zoom, I want to let you know that the chat function is not available. Live closed captioning is available, and you can ask any questions to the Q&A function, and we'll be ready for those questions. And there'll be a set of poll questions at the end of the webinar. The next slide, please. As you know, this lecture is named for Dr. Poussaint, and I'd like to just share a few words with you about his life. For those who are not familiar, Alvin Poussaint was a professor of psychiatry at Harvard Medical School, but that sounds so small because he was so much more than only a professor of psychiatry at Harvard Medical School. He meant so much to so many. He was an influential psychiatrist, a scholar, an advocate for equitable access and opportunity for everyone. He served as a faculty associate dean for student affairs until his retirement in 2019. He was the founding director of what became known as the Office for Recruitment and Multicultural Affairs, that office having started in 1969. The author of numerous books and articles and involved in media on multiple levels. But he had this particular focus on the raising of young African-American children. Before all of that, he served as a Southern Field Director of the Medical Committee on Human Rights and was involved in that 54-mile march from Selma to Montgomery. He has been and continues for many of us to be an example of how we can think about advancing the causes of health equity and dignity for all. His voice and actions carry tremendous power, so it's incumbent upon us to carry his passion forward through our commitment to justice and equality and health and well-being for everyone. This lecture, this visiting lecture, was actually established through a gift of HMS alumni in honor of Dr. Poussaint. And the purpose of the fund they established was to provide an annual lecture, a forum for connecting Harvard Medical School alumni leaders in medicine and science with our students and trainees and fellows and our faculty in the medical school and in our affiliated institutions. This marks the 21st lecture with Dr. Poussaint having given the inaugural lecture. So our 20th visiting lecture is Dr. Woodrow Myers. Dr. Woodrow Myers, known to some of us as Woody, okay, is a physician and a nationally recognized leader in public health, the development of medical quality initiatives, and the advancement of healthcare management programs. As managing director of Myers Ventures, LLC, he's coupled his passion for the highest standards of patient care and management with leadership roles in several of our nation's largest and most innovative healthcare enterprises. Today, he serves as an advisor to LightSpeed Venture Partners and to Free Spira and the board of Personalis. He's a member of the Public Health Policy Committee of eHealth, Inc. He served in many capacities as Chief Medical Officer and Chief Healthcare Strategist for Blue Cross Blue Shield of Arizona, CEO of Valitas Health Services, otherwise known as Horizon Health, consultant for the California Endowment. He served on the board of overseers in multiple positions with both Stanford and Harvard and with Drew. He has been in healthcare management, really having led a director of healthcare management for Ford Motor Company. Prior to that, he was director for the Associated Group. He's a former health commissioner in New York and the state of Indiana. And what I'm hoping you're hearing is the story of a a life and a career that has been deeply, deeply committed to improving healthcare and quality and availability for everyone, and someone who has been willing to step into leadership and to hold the fort, to make spaces for us to come behind. He's a graduate of Stanford. I'm just going to go. He's a graduate of Stanford, but he got his MD here at Harvard Medical School. That deserves a clap. Come on, man. All right. And then for some reason, he went back to Stanford for an MBA. I don't think you can stay away from there. And he did an RWJ Health Policy Fellowship at Stanford and a Critical Care Medicine Fellowship at Stanford. But as much as I know he loves Stanford, I know his heart is always here. And it is such an honor to have you here with us today, Dr. Woodrow Myers.
Thank you for that very, very kind, overly kind introduction, Dr. Reed. It's a pleasure to be back. I hope, is my microphone working okay? Is everything, the green light is on? All right, good. I only found out 5 minutes ago that this was also on Zoom. I didn't realize that until I was informed. So I hope the folks out in the world of Zoom and or Teams or whatever technologies you're using are able to hear me okay. I'm going to move around a little bit. I hope that's okay as well. I am just honored to be back in this room. As I was saying to a few folks earlier, my first journey here was back in 1973. That's the first time I was in this room. This room has lots of memories. It's the room where I found out where I was going to be an intern back out at Stanford University. I was remembering our match day, which just came up for you guys relatively recently. I've been involved in many other events in this room, including a press conference to slam the remarks of Harvard professor Bernie Davis back in the 80s, where he made extremely awful negative comments about medical students, African-American medical students in particular, and Hispanic medical students here at Harvard. We could talk about that later if you'd like. But it's a room with a lot. It's good to be back. It's good to be back at a time when we are able to really discuss the important issues and for me to get different perspectives. I only do these because I get to learn when I give a talk. It's the interaction with you afterwards, and I'll try to make sure that I stay in my time limit so that we can have questions or queries or debates or whatever you'd like to do. So with that, let me get started. I think it's important today. We didn't do this in the old days where you had to do financial disclosures, but I thought, well, okay, let me follow the protocols. And these are the financial. I don't think any of them will interfere with what I have to tell you today. And in fact, Joan has already done most of my work today in terms of the early part of this talk. My goals are relatively straightforward. To share the perspective of one HMS graduate on our current state of inequality and injustice in healthcare, to share opportunities to influence potential and future consequences, perspective profoundly influenced by my life with Alvin Poussaint. And I'll talk a little bit more about that in a second. I'm also here to offer a sample for those opportunities for significant influence that masquerade as career choices. I'm really here. All of you that are kind of late stage career, you're welcome to stay. But I'm really here for the group of students that are here that are about to make big decisions, because I believe that there's lots that you can do, and I'd like to help you figure out what that is. And then to remind those still, as I said early in career, of the key elements needed to achieve success. So those are my goals today. And this is the mantra under which I operate. I saw the movie From Montgomery to Memphis way back when I was a Stanford freshman. I was supposed to be at a bowling tournament. I was a pretty good bowler, believe it or not, in the day. And I let my bowling team down that evening because they were showing the movie From Montgomery to Memphis in a dorm across from me. And I said I'd stop in and watch it for 5 minutes, and I stayed there for the next 2 or 3 hours. And I really saw in that what was going on, especially in the southern part of the country with respect to civil rights. I remember where I was on April 4th, which is coming up pretty soon, April 4th, 1968. I was 14 years old. I had just finished playing basketball outside with my friends. I came into our home, I turned the TV on, and there was a special report. And I think those of you are probably figured out where I'm going. That was the evening that King was shot in Memphis. And I stayed glued to that TV as a 14-year-old for the next 4 hours till I couldn't keep my eyes open. I was angry, and I was trying to figure out, what am I going to do? Everybody had a responsibility to do something. And I remember that was a moment that was very important for me to figure out, how am I going to respond? You know, a lot of people responded by rioting in various cities across the country. We didn't have that much rioting in Indianapolis. But it was a pivotal day for me to make a decision, and this was one of the influences I had in making that decision. Well, let me just make sure you understand, I've had a lot of different roles at Harvard. This was the picture I sent in for my application. I am shocked that anyone would let that guy in to medical school. At least I had combed it. You know, it's like most of the time it wasn't combed at all. These are some of the roles I've had at Harvard over the years, and the different hairstyles that I've had along the way. And I only say that this slide is a preview to what I really want to show, which is this one. This shows Alvin at an early stage of his career. And this is Alvin on those marches in the South. I believe this is the march to Selma. And the Medical Committee for Human Rights. And this is Alvin, as you saw later on. Here are some of the books that he wrote throughout his career. But one of the things that Joan didn't mention that was very, very important, Alvin was a consultant for one of the most popular TV shows in the history of television, and that was the Cosby Show, and then for a spinoff of that show called A Different World. That made a huge difference because those shows were very influential for my generation and the generation afterwards that saw all the repeats. He did a lot of amazing things, not all of which are given equal due. He was an incredible guy, and it meant a lot to me in my career. And it's hard for me to overstate what he did for me. I would also like to make sure that everybody understands that your career doesn't always go the way you want. There was a controversy that doesn't get talked about a lot in Alvin's career. He wrote for the textbook of Black-related diseases. He did chapters in this book and in other publications. Let us just say that we're not central to the teachings of the Harvard Medical School in those days, but he nonetheless published in a variety of places. But in addition to his work in the Dean of Students office, he was at the Judge Baker Guidance Center. They call it something different now, the Baker Center for Children and Families. And he established something called a Campaign for a Commercial-Free Childhood. And that campaign identified a promotion that the Disney Corporation had put out as educational, when in fact it was, from the opinion of Alvin and others, much more a business that masquerading as an educational opportunity, and demanded that Disney change its posture on that. Disney ultimately did not like the publicity that Alvin created and capitulated and gave people their money back if they thought it was educational when in fact it was not. But at the same time, the board, I believe it was, of the Judge Baker Center tried to muzzle Dr. Alvin Poussaint and told him not to talk about it publicly. Instead, he resigned from his role there. I don't know all those details, but it just shows me the courage that Alvin had. There's an article about it in the New York Times that you can read the first paragraph of there. And later on in his career, right near the end, he received yet another one of his many awards, this one from the American Psychiatric Association. So into every life, a little rain must fall, but your friends are still going to be your friends. And if you do what's right, you're going to be okay. That's the message. And Alvin, from everything I saw and did exactly that, what was right. So Let's talk a little bit about what Alvin fought against, structural racism, the normalization and legitimization of an array of dynamics, historical, cultural, institutional. And I'm not here today to focus just on racism, but that's part of what gave Alvin his purpose in doing many of the things that he did, and gave me a purpose as well, fighting against something that we knew was wrong. And by the way, this definition is not one that Woody Myers made up. This is the official definition of the American Medical Association. I got to tell you, I joined the American Medical Association in 1974. I joined at the earliest. I got the little student membership when you got the discount. I joined it because I wanted to be a part of the leading organization in the United States with respect to changing our profession. And in those days, I guarantee you the American Medical Association did not take some of the positions. It would have been incomprehensible for the AMA when I joined to have a definition of structural racism and have efforts underway to fight them. But the AMA has changed. The point I'm making is that if the AMA can change and become a leading advocate, so can other institutions as well. Institutions are not static. Institutions are a creation of the people that run them. And many of you in here are going to run those institutions. In addition to structural racism, there's implicit bias, and that's a different focus. The implicit bias is defined as an unconscious attitudes, positive or negative, towards a group of people or an idea, often leading to differential treatment on perceived race. Emergency department data shows that Black ED patients have a lower likelihood of admission. There's just a ton of information now from a number of scholars from here and elsewhere that shows that implicit bias is real. All of us in here have biases. Some of them are worse than others. Some of us are aware of our biases. Others of us are not. It's an interesting area for which there is a great deal of research, a body of research today that it's important for you to understand, especially for those of you who are becoming physicians, because those biases you have may contribute to your ability to take good care of your patients. So it's something you should be aware of. So today we're going to talk a little bit about disparity, which is the difference, just a little bit about inequality, the difference tied to social hierarchy, and then injustice, the difference judged as unfair and preventable. These are the terms that we use, unfortunately, sometimes interchangeably as we talk about the impact of structural racism and implicit bias. And this is not a lecture on all of those issues. It's just a flyover to kind of get you ready for what I really want to talk about, is how you use this information to decide what you're going to do, as I stated in my goals for this presentation today. A healthcare disparity becomes a healthcare inequality when it follows social advantage, and the disparity becomes a healthcare injustice when it is avoidable and rooted in unfair systems. Look at these data. Life expectancy at birth across all races and ethnicity. This is a relatively recent post-COVID information is there. And you look at the group at the top, the data for 2023 of life expectancy for those in the highest category, the Asian category is 85.2. The lowest category, the American Indian Native Alaskan is 70. That's a difference of 15 years. If you look at what happened, COVID 2021, it went up a little bit for Asian, but look at the lowest category, 65 to 70, the differences between the 83 and the 65. Those shouldn't exist. That's wrong. In my view, and I'm not a lawyer, that's prima facie evidence of a huge problem that my generation has failed to solve and that your generation is now faced with dealing with. Black, Hispanic, and AN adults are more likely to report fair or poor health status. This is not looking at it from the point of view of statistical analysis. This is what people say about how they feel about their health. And as you can see, there's a pretty significant, almost threefold difference between the various categories that are listed. How you get your care covered, your healthcare coverage is very, very important. This is not going to be a lecture on healthcare finance, but it's important to realize that still in the United States today, about 92% of folks are insured. There's lots of different kinds of insurance, private, public, military, and there's various subcategories of each of those that each of you will become more and more aware of as you move forward in your practice. But 8% are still uninsured. One of the things I'd like to tell you about that 8% number is that pre-Obamacare, it was double that. One of the reasons I believe there's still such a political kerfuffle, did I say that word right, over Obamacare is because it was successful in cutting uninsured by half in the United States. And that was a pretty good jump. It's your job to cut it by half again. So I'm just putting that out there on the table. This lecture is not for free. You got to do something about what you're hearing today. So this is healthcare coverage for children ages 0 to 18. And what I want to point out for Black children and for Hispanic children, the vast majority of the care that's given today in 2023, and it's getting more, not less, are in public programs, Medicaid and other public programs. Half of the births in the United States today, 1/2 of all births are on the Medicaid program. So if you're family medicine or OBGYN, Medicaid is something you need to know a lot about because the way that the healthcare finances are going, you're going to spend a lot of your time dealing with the proclivity, the vicissitudes, let's put it that way, of those programs. If your age is 19 to 64 and you're Hispanic, 23% are uninsured, so that 8% that I said earlier doesn't apply. And if you're AIAN, American Indian or Alaska Native, it's 21%. So again, uninsured population has not gone away. It's gone down. So there's still a lot of things out there for your generation to fix. So healthcare disparity, again, is the measurable difference in outcomes. And I'm going to use maternal mortality as one. I could have put cancer up there. I could have put injury. I mean, there are a lot of different stuff, but you can't talk about everything in 40 minutes. So I just picked maternal mortality, and you'll see in a minute why I chose that. You can see that Black women are 2 to 3 times more likely to die from pregnancy-related causes. This is a statistical difference between groups. It doesn't explain why the difference exists. The disparity is the number. Now, I like these little graphics that you can get all over the internet today, describing in graphic terms the difference. A disparity is the reality. Some people get what they need. Other people get more than they need. And some people get less than they need. So remember that. You can see that there are a lot of different reasons for maternal deaths. But what surprised me is that the top 3 unintentional drug OD violence aren't necessarily OBGYN related. I didn't, until I started thinking about this in a lot of depth years ago, it didn't realize that's not what you get in the OBGYN curriculum. It's not what they spend a lot of time talking about. You do spend a lot of time talking about fetal embolism, or excuse me, amniotic fluid embolism and infection and hemorrhage and some of the other causes. But maternal mortality has got a lot of deeper issues related to it, societal issues that I think are important to understand. Now, just to be completely fair, are there health disparities that favor African Americans? I've showed you a couple that chronic respiratory diseases and mortality was lower in the Black population, neurologic disorders, a few of them, unintentional injuries. The stroke survival paradox, people are writing about that. Why do I put this slide up here? Because it's important. Why do those disparities exist? Is there something we can learn that we haven't figured out yet that apply in those areas and or related areas that I think would be important to use to determine what research we should approach to eliminate disparities for all populations. So we move from that to healthcare inequality, the unfair and avoidable differences in healthcare outcomes. And there are many components of healthcare inequality. The social determinants of health is what we talk a lot about today as sort of a way to summarize what those are. These are the social determinants of health. Please, if you look them up, there's just a ton of work out there. By the way, I hope everybody here who has on their phone opportunity to get into a program that is called Open Evidence. Open evidence has really replaced remember in the old days, some of you in this room remember the Washington Manual, where you were an intern, you carried the Washington Manual around in your pocket. You kids don't know what the Washington Manual is. It was from Washington University, St. Louis. They had this little cheat book that was cheating, right? It's a way to take care of your patients, all in one little book. It told you how to put in a chest tube, told you how to prescribe certain drugs. The open evidence has replaced the Washington Manual and all the other ones that were out there. And I think that it's terrific. And it also talks about other things in healthcare, not just the clinical side, but issues like the social determinants of health. So it's a great source of what I consider factual information about what's going on in healthcare today. And there are others out there, but it's one that I wanted to give a plug to because they're really very good. I think the more you know at this age and stage about social determinants of health and how they impact the specialty that you're choosing, you're going to be a lot better off. Because you're going to wonder over the years as you move forward, why is it that some patients get this? Why is it that some patients don't? And what is it that I can do about it? Well, if we could fix some of these determinants, then I think there's a lot we could do about it. Healthcare inequality is when the disparity is linked to a social advantage or disadvantage. And in the maternal mortality example, there are a number of reasons why that you can point to. I believe that inequality is still a huge and will be a huge problem because everybody thinks about it. If everybody gets the same thing, then we've now become fair. We've solved the problem, haven't we? Well, no, we haven't. Because even if you provide, quote, equality, there are still folks that need something in addition to that in order to make it. We also, I pointed out in red, the chronic stress from discrimination. For those of you in the room that are research-minded, cumulative lifespan stress, inflammation, and racial disparities and mortality between Black and white. There's a lot of information that's coming out today that says inequality, stress, they have real impacts on folks' lives, and you can measure them. And the importance to individuals is unambiguous. There's higher mortality. The main outcome measures, there are a lot that you can look at, like C-reactive protein, interleukin-6. And the conclusions are clear. The heightened cumulative lifespan stress and elevated inflammation were associated with shorter survival. Why is that? How does that happen? How does this human body know that it's stressed and this one does not under the same circumstances? What is it that causes us to react differently biologically? If you care about these issues and science is your thing, this is a great place to learn a lot more about that. Much more than I can contribute. It's called the allostatic load. It's a physiologic measurement of the cumulative wear and tear on the body resulting from chronic stress exposure. It's composed of a variety of four biologic systems, a variety of areas. There are a lot of different ways that are being used to measure it. And increasingly, we're learning that the magnitude of disparity is real. By the way, anybody that wants these slides, there's nothing proprietary about them. If the folks that organize this want to find a mechanism by which to transfer access, I'm perfectly okay with that because I'm going pretty fast. And I'm doing that because I have a lot to talk about. But I want to stimulate thinking from a variety of directions. It's not all this, it's not all that. You can attack these issues both from a biologic and a social perspective. Healthcare injustice, the unfair, avoidable, and systemic barriers that prevent certain groups from accessing the same quality of health and healthcare as others. There are a number of key elements to injustice. And this is kind of where I thought I needed to spend a great part of my career. We'll talk about that a little later. There are many examples in maternal mortality. How is it that Black women with college degrees still have worse maternal outcomes than white women with no high school diploma? How the hell does that happen? Why does that happen? There are people in this room who have the skill to figure that out. I don't. I just know that there are people who've done the research to prove that it's true. It'd be very important for those of you who are so inspired to actually learn what those issues are. Justice is the structural and systemic where the structural and the systemic cause of inequality is addressed. Everyone can come as they are. So this little graphic shows what justice might look like from that same graphical perspective. So the key elements of this conversation today, disparity, inequality, and justice, they all have specific meanings, and there are all kinds of examples in the past and the present. But I really want to talk mostly about the future. What are the prospects for future improvement in maternal health mortality? There are a lot of things that people are doing that are making a difference. Standardized clinical protocols, quality improvement initiatives. One of the group that I've met with today from the Commonwealth Fellowship Program, I think might be a good candidate to take this on. Group prenatal care, patient navigation programs, expanding access to diverse birthing options, implicit bias training. These are all been proven with respect to the literature as ways to improve maternal health mortality, and then addressing the social determinants of health by expanding healthcare access, increasing funding for rural hospitals especially, improving data collection and quality measures. There was a legislation called the Black Maternal Health Omnibus Act that did that. Training healthcare providers to identify and address the intimate partner violence issue, which is real and it's huge, and then access to publicly funded services, particularly family planning and prenatal care. I just use maternal health as an example to talk about disparities, to talk about injustice, and talk about inequality. But what I really did was to use that as an intro to Woody Myers' interest in these issues. How does a Harvard medical student come here with all of the brilliant scientists around and get interested in this stuff? Well, I'll tell you, I came to the second year of medical school. I was going to be an OBGYN. That was my career. I knew that was where I was headed. I did a little homework, and I learned that if you did your clerkship at the Women's Lying-In Hospital, I talked to some of the African-American students that had done clerkships before me. There were issues with being allowed, quote unquote, to participate in the births of certain patients. It was let's say, a Brookline heavy population. And they frequently didn't want any medical students, especially medical students that had the kind of hair that you saw earlier in the picture, participating in the birth of their child. So the thought was that you only got to do 3 to 5 deliveries at most. And then I learned about USC Los Angeles Women's Hospital. It's the second largest number of births in the United States, behind only Baylor, and they were barely behind Baylor. Babies were dropping out everywhere. And they let medical students they needed the help. They let medical students come from all over the country. I said, if I'm going to be an OBGYN, damn it, I'm going to deliver some babies. All right, so here I am, second year medical student. In order to get your core OBGYN clerkship approved as counting, you had to get permission from the chair of the department. He had to say yes to your getting this. And my rationale was that here I am, second year medical student, saying the Harvard experience was inadequate to my needs. But I had to go see Dr. Ken Ryan, who is a professor of obstetrics, well known in reproductive biology. And I had to convince him to sign the piece of paper that would let the registrar know that my course at USC-LA would count towards my OBGYN clerkship. The length of the meeting was less than 10 minutes. I started into my argument. He saw that I was passionate, and he said, basically, I got too much shit to do this afternoon. I mean, this is me. He didn't say that. He signed the document. He said, good luck, Dr. Myers, or something like that. And I said, the meeting's over. I got it. I mean, I was geared for battle. But I said, wow, okay, all right, let me get out there. And so I had, in 5 weeks, Woodrow A. Myers, 55 deliveries. In 5 weeks, babies were dropping everywhere. So here's what happened at Big County. We called it Women's Hospital. The residents and the fellows did not want to do normal spontaneous vaginal deliveries. They only wanted to do forceps and C-sections. So they let the medical students do all of the vaginal deliveries. I'm up for that. So they showed me about 3 or 4. And then I was on my own. Here I am, barely a second-year medical student. And I am in the delivery suite. Me, frequently, not always, a nurse, and the patient. I had to learn a little bit of Spanish because I could not speak to my patients. 80% of them spoke no English whatsoever. It was an interesting experience, let me tell you. But there was one patient that didn't go the way that the 54 went. This is every talk, medical talk, should have a case presentation. During the 4th week of my clerkship, there was a 35-year-old gravidified para-4 who presented to the ER reporting early labor. She had no prenatal care, minimal English, a history of diabetes and obesity, automatically placing her at high risk. I should have never been the guy or gal to actually, as a medical student, do this. She was a passenger on what we call the Tijuana Express. Basically, what happened is that women in their 8th month of pregnancy would come to the border, and there were folks that helped get them across the border, and they would find their way to Los Angeles, to the big county hospital, where the word was out that you could get your delivery done. They weren't going to hassle you. And what did you get out of that? An American birth certificate for your baby. And so your baby became an American citizen, which was very, very important to a lot of these mothers. The patient was admitted to labor and delivery led by senior medical student, Woodrow Augustus Myers. She was fully dilated. Head was visible in the vertex position, but she was pushing without progress. And then I noticed something funny. The head seemed to retract. The OBGYNs in this room automatically know where I'm headed, right? This was called the turtle sign, when the baby's head emerges but retracts back against the perineum, like a turtle pulling its head back in the shell, but it can't get it back in. Why? Shoulder dystocia. It's one of the complications that we heard about in lecture. And that Woodrow A. Myers in his 4th week had in front of him. And I'm sitting there thinking, why is she pushing and nothing is happening? She's a gravidified para. This should be easy. It's not. So what? And then all of a sudden, oh my God, I remembered the lecture, shoulder dystocia, right? And then I didn't quite remember the whole acronym, be calm. B, breathe, do not push. E, elevate the legs into the McRoberts position. C, A, L, M. The only part that I remembered was the C, call for help. I was in the labor and delivery street. I said, oh my God, if I don't do something right now, she's going to die. And I screamed as loud as I could, I need help in this. And then the chief resident just happened to be walking by, heard what my plea for help, burst into the room without any gloves, saw immediately what was happening, got me out of the way. And for the OBGYNs in the room, you know what came next? The McRoberts maneuver. And every time I see a TV show, the ER or the pit or any of them, I want to make sure they're giving the story right. Because the one thing you absolutely must know is the McRoberts, because you save a life if you don't do it right. He did the McRoberts. I spent the next 2 or 3 hours sewing up the lacerations that occur as a result of this. And to this day, I wonder, did the baby suffer a neurological complication? Maybe because Woody Myers didn't recognize it soon enough. And then I wondered a lot of other things. Well, why did I deliver her? Why wasn't she? There were other people who were better. I mean, and then all of these things hit me at the same time. It was frightening and confusing for this second-year medical student to figure out. What was the issue? Was the issue that the patient, I don't know why that slide isn't doing the right thing here. I don't know if there's a way to restart it or not. But the issue was the delivery often occurring outdoors in Mexico. That was no good for her. Or the reliance of pregnant Latino women on the obstetrical skill of a second-year medical student. Or what the top section says is that the Harvard-Boston lying-in experience perhaps wasn't so bad after all, because she would have had a professor of OBGYN to take care of her. I think my slides are stuck, and so I need one of the experts to move me one slide forward, if that would be okay. This was a pivotal, to this day, a pivotal moment in my career. Uh, uh, Thank you very much. Injustice and inequality is real. How does one spend a career to accomplish the most to fix it? That's what I want to suggest to you today. These were my career options at the time. I told myself that perhaps lying in wasn't so bad, but and maybe I could approach, if I spent the career properly, the 13, which was much better than the higher numbers that you see. So perhaps I needed a career in academics, or did instead I need a career in public health in order to fix the problems that I saw at Big County in LA, because they did more than just let medical students take care of babies and moms. They did a lot more than that are very different from the standards that we had at Harvard. Or did I belong in politics to fix the issue of why mothers were delivering in the field? This was the pivotal moment in my career at Harvard, so that I had to figure out kind of which direction they needed to go in. I also wondered, did the race of the provider healthcare have any impact on healthcare impact? What if I had been able to speak Spanish? Would that have been better for that patient? And what if others who dismiss African-American patients' concerns, i.e. Serena Williams and others that you can read about, what would happen if we had better understanding between cultures and races on these issues? Racial concordance between physician and healthcare providers has been shown, particularly for Black patients seeking Black physicians, as being associated with improved health outcomes. Is that sufficient to increase the number of African-American students that are trained in medicine in the United States? Or is that just an incidental finding? Minority physicians are substantially more are likely to minority patients are substantially more, physicians are more likely to see minority patients. That's been shown as well in a number of settings, and that the higher primary care physician representation in U.S. counties is directly associated with improved healthcare outcomes. A lot of great research is being done on this issue, but I don't see a lot being done with the results of this research. If you could take a quick look at the distribution of people by race and ethnicity in the total population of the physician workforce, African-American patients are double their percentage as African-American physicians. And this slide is thought by some to overrepresent African-American physicians today. The percentage is going down relative to others. If you doubled the proportions, it'll take less than almost 100 years for Black and Hispanic medical student matriculants to reach population parity. And with the Supreme Court decision in 2023 that's impacted just about everybody, that number goes up even higher. So maybe that's an area for some of you to pursue. Medical school applicants have gone down. If you look at the blue column, which is the African-American student applicants from 2021 to 2025, if you look at the matriculants, i.e. the people that get into medical school and then go, that number goes down as well over the same period of time. And you pick up Black medical school applications and matriculants and put them beside each other, you can see the bad news from 21 until today. There's a box at the bottom that's empty. What I hope to put in that box cleverly was the percentage of African-American admissions in the first year of medical school in 1974 or 73 when I got in, and in 2026. And I'm pretty good at finding things out. I couldn't find anywhere the published number about the percentage of African-American medical students at Harvard. It's a closely guarded secret, but my guess is it's pretty much the same as it was when I got here, which was at the height of Harvard interest in African-American medical students back in the, I don't know that for a fact. I wanted to give you the data, but the data are not available. And I wonder why. This guy was very important. This guy, Bob Ebert, is that guy right there. He was my dean. He told us in class day at the Harvard Medical School in '77, Harvard has taken the lead in recruitment of minorities into medicine and it must not now back away from that enormously important commitment. That was my dean saying those things. I wonder if deans today are saying similar things. I don't know. So how do you fix the future of inequality and justice in healthcare? We're getting to some of the punchline here. You can't just write a prescription to get it done. There's politics, there's technology, including AI. There's complete overhaul of the medical education system with a rethinking of the role of physician in clinical care. And there's the continued need to navigate and then eliminate the unnecessary non-value added complexity of the processes of care. There are a lot of ways to fix the problems. How does one decide? You got to decide whether you are a loner or you want to work in a system or a group, whether you want to work part-time in this or are you a full-time revolutionary, whether you belong in the academic world or what I call the real world, local or state or national or international, the public sector or private sector, and what kind of salary, what kind of income. Those are some of the decision points that each of you are going to have to make as you make your decision. And I've made all of them, more than once. I tell you, it's difficult. I think, though, that each one of you is capable of making that decision. These are some of the choices that I've made in my career of things to do to help fix the problems. Each one of those had its own pluses and minuses. I'm not saying this is a model for anybody here, but I am saying there are lots of different ways for each of you to make a difference. And I would encourage you to think about that and to understand where your personality is and decide to take a chance on some of the various opportunities that you have in front of you to make that difference. These are slides, all of which I took. Oh no, our slides are stuck again. Could I get some help, please? This is 1988. I was on a mission to evaluate the health system of the country of Mozambique. These are slides during the war between Frelimo and Renamo, where backers of the Western versus the Eastern, I won't go into all the politics, committed atrocities that I never seen one human being commit to the other until I saw war up close and personal. Don't tell me human beings are capable. I mean, we are capable of love, but we are capable of enormous hate as well. This is a little boy whose head was bashed in by a rifle butt during this conflict. I was foolish enough to ask where the nearest CT scanner was as we saw this kid. There was no CT scanner in the country of Mozambique. As Health Commissioner of Indiana, the debate was whether we should have 10 or 12 scanners in Indianapolis at the time that I was there or not. The little boy did not do well. And then you fast forward to 1988. These are shots of Coachella, California. Not the Coachella that you hear about, where you pay a bunch of money and you spend time in the desert. As you can see, these are little homes that are being built by folks near the railroad tracks. These are materials that they take from various areas, some of which fall off the train and build them. And this is one of the builders, the woman on the left, who's being helped by a member of a team that I work with, the Wellness Equity Alliance. So things sometimes seem like they don't change at all. Sometimes they change very quickly. But here are two examples in my own career of areas where I've wanted to see far more change than has happened. So let me tell you about a system very quickly that works. Healthcare coordination is real. You get 20 minutes a patient. You get to see your work online. There's lots of population management tools and registries. Lung cancer screening is measured and it goes up. COVID deaths were really a rarity in this system. And this is like recent. How the hell does this happen? Where the hell does this happen? And then you take a look, and it's the California correction system. Folks in prison being cared for by physicians in that system. And if you look at what some of the salaries are, I think you might be surprised. For salary for a time limited, board certified, or limited board, 300. This is like a year ago. So my guess is they've gone up. And then I decided to compare those salaries to the U.S. Public Health Service, to a starting primary care doc at Mass General Brigham, Indiana University, and UCLA Health, and you will see a magnitude of difference. So isn't it unusual? How do we feel about the fact that the folks who are doing, now, I tell you that the reason the California healthcare system in the prisons got to be this way is because of a federal judge who took control of the system for more than a decade and forced the California legislature to spend money where it doesn't necessarily want to spend money. But should we feel happy for the system, or should we wonder why is it that you have to wait until you get in prison before you can get the kind of care that is optimal compared to care outside of the prison system? And this is something I know a little bit about because I was the CEO of the largest provider of healthcare to prisons and jails in the United States, a company called Horizon Health for several years. So primary care physicians are instead moving rapidly into what we call concierge practices. If you can see, it's double from 2018 to 2023. These are practices basically where you pay a fee, and there are a variety of different ways to do it, to get the cell phone number of your doctor. That's basically all it is. It's very common in Manhattan. It's increasingly common in other major metropolitan areas. It's a lot of them are primary care internists, they're general internists that are doing these changes. So what direction are you, the folks in this audience, going to go? I would encourage you to learn a little bit about your personality types, because some personality types do better than others. I think that you can do well by leading in any of these organizations and I've grouped them here, from medical associations all the way to political advocacy and political action committees. You can do it part-time, you can do it full-time, but there are ways in each of them to make a huge difference during your careers, or you can make it a career. It's something that if you care about injustice and inequality, there are ways to do it in addition to taking care of your patients. Or you could choose to run for office. Don't run like I did. Yeah, I want you to win. I lost two big races, one as a congressional candidate and second as a governor candidate. But look at this, 17 positions in the House of Representatives, and you could be, I mean, if I had the time, I could have put nurses and other healthcare professionals up. We are doing a lot better than we used to. 4 in the Senate, 1 governor, most are Republican, and some of those Republicans have what I would call good sense. All of the Republicans on that list in the Senate voted for Robert Kennedy. I don't know how many of them regret that decision. If I were in their shoes, that's a decision I would regret, but that's probably too political for this kind of a presentation. I think that you also need to understand that the world is changing with respect to AI. This is a company called Doctronic. Keep your eyes on Doctronic. Keep your eyes on Doctronic. You go online and you put in your problem. And Doctronic comes back and tells you what to do. It's not like ChatGPT. There's a number of studies that have shown ChatGPT doesn't give you what many of us would consider to be the right answer. Doctronic is a hell of a lot better. Doctronic has secured $20 million in Series A. Let's just say they're doing extremely well. I used to be an advisor for LightSpeed Venture Partners. They're one of the major backers. I'm not an advisor today. Doctronic now has permission in the state of Utah to write prescriptions. Think about what that means for a second. I go on Doctronic, I tell them I've got this, this, and this. And in certain categories, not for every diagnosis, the script can be sent to Costco and I can pick it up. And that is my medical care. With Doctronic, if you spend $39, you can actually speak to a physician once you fill out the form. $39 gets you a Zoom type visit with the doc. I've never tried it, but I'm told they're pretty good. That's the future. Is that a good thing? Is it a bad thing? A lot of the investment community thinks it's going to be a profitable thing. That's just one example, and I've already told you about open evidence. They are just killing it in terms of their successes. Founded in 2022, the October valuation in 25 was $6 billion. How many months between October and January? I haven't counted that. The valuation has increased substantially. 1 million clinical consultations between verified doctors in the AI system in a single day. And I use it, honestly, I use it once or twice a day, and I'm not even actively clinically practicing. You can ask it anything. And good news, it'll tell you when it's beyond its scope. You can, it said, come on, Woody, we don't do that. You know that. It doesn't say it exactly that way, but it's pretty close. And it's free. It is free. If you have an NPI number, which means you're a legitimate doc in the United States and you get Medicare, Medicaid, it's free. So here are your chances. How do you fix the future of healthcare and inequality and justice in healthcare? One, you can go to politics. So here are your jobs in 2046, which is what, 20 years from now, right? I asked a number of you what you were going to do in 10 years. Here's what I expect of you in 20. Become the chair of the HELP committee and the Senate, House of Representatives chair of Ways and Means. That's where the power is to make changes in Medicare and Medicaid. What percentage of kids, Black and Hispanic, are getting their care from public programs? 60%. By 2046, it'll be 75 or 80%. Think of the difference you can make if you run those committees that make the decisions on where the dollars go in those public programs. Or you can become governor of Texas. Why Texas? That's where most of the growth is. And if you can do it in Texas, you can do it anywhere. Texas is becoming more the mean of the country. And so, and I didn't mean that in a mean way. I meant that from a statistical way. Technology, including AI, is a way for you to go. Of course, you can become CEO of Apple or Google or Microsoft. Nothing wrong with any of those. But CEO of a new startup, low-cost oral diabetes management company. That's where we're going with management of diabetes. The GLP-1s work great. We haven't quite got the oral stuff down now, but the company that dominates in my city, Indianapolis, Eli Lilly, they're doing pretty darn well. And when they get the oral done, trust me, the world of management of diabetes is going to evolve rapidly. Or, by the way, the #1 cause of preventable deaths in the United States is tobacco. Still, I mean, why don't they teach? Why isn't there a giant headline every day saying the #1 cause of preventable death in the United States remains tobacco? We needed something that eliminates the desire to smoke. We've got something that eliminates the desire to eat. Why not something that eliminates the? Those of you who are clinical pharmacology minded, you get that idea. I would like a thank you note in 2046 for putting it in your head today. Complete overhaul of medical education combined with the rethinking of the role of physician in clinical care. I really do believe this is required now. What is the role of the physician today versus when I graduated? What will it be in 2046? The National Academy of Sciences is a good place to have that influence. A dean of a medical school. Why did I put Arizona State up there? I had to show my love for both Stanford and Harvard. Arizona State is one of those places they don't pay attention as much as a lot of other places to the norms. They just created a brand new medical school and they're revolutionary. They want to break rules and then ask for permission later. Maybe that's a better way to go about it than one of the more traditional spots. And the University of Texas, why? Texas is becoming the mean for the United States of America. President of the AMA or the chair of the next Flex. Everybody here know what the Flexner Report is? The Flexner Report back in the 1910, I believe it was, is the report that really changed how medical education is done in the US. Look it up, Google it. And then finally, continue to navigate and eliminate unnecessary non-value-added complexity in the processes of care. There are a lot of different ways, some of which I can't think of, so I put X of X. There are a lot of different points where you can make a huge difference, and it doesn't necessarily say you have to have an MD to do it, or it doesn't necessarily say you have to have an MPH, or it doesn't necessarily say you have to have an RN, but if you've got the interest in the smarts, and if you were smart enough to get in here, then you're smart enough to help fix these problems. So what your colleagues will tell you when you say to them that instead of going into gastroenterology where there are a gazillion colonoscopies to be done, they will tell you that problems are too big and too complex, just like Sisyphus. You guys are liberal arts graduates. You remember the Sisyphean, what had to push the rock up the hill and it kept rolling down. Problems are too complex. There's not enough time in your career to get it done. We can't have a family and do it at the same time, or that the racism will never disappear. So you're fighting an uphill battle. Well, you know, a lot of people have fought uphill battles, and you get partial victories, and sometimes you win, and sometimes you don't. But I think if you put your career and your heart into it, you're going to win more than you lose. And sometimes you got to fight the battle to give other people time to see you fight the battle so that they can fight the battle after you're done fighting the battle. And that's kind of how I see myself. I have fought all of the battles, and I have won a few and I've lost a lot. But I'm still here, and I'm telling you that in order for these battles to be won, people in this room have to take it up and take up the charge and take up the flag. And you have to think about the Women's Hospital of 1975 that allowed Woody Myers, second-year medical student, to take care of a patient that he damn near killed and remembers to this day. And if I could find the little card that I made on that patient, it's buried somewhere in a box in some storage shed that I got somewhere. And if USC would allow me to go back in the records, they probably don't even have them from back then. I would look to see whether that kid developed some kind of brachial plexus injury or something that I should have fought and spent his or her life doing something. I mean, it haunts me why I was allowed to do that and what the implications of that could have been. So it's up to you guys to look at the Women's Hospital of 75 and to do what's required, and that is to tear down those walls and put something different up in its place. Your job is to destroy that which is no longer valuable and create new value. And you're smart enough to do it. Don't let old people like me tell you it can't be done, because it can if you put your heart to it. This is my speech to Class Day in 1977. I looked at that and I said, that was pretty prescient. We must reorganize organized medicine, take an active interest in government, and we must never compromise human rights. I got that from Alvin Poussaint. He was my inspiration to do the things that I have done, and I am so glad. I hope I made him proud. I hope I did some of the things that he had thought that I might do. This is us on Class Day together. Unfortunately, I think this might be the last. Although he lived to 12, we weren't smart enough like you guys are. You were always taking pictures. We didn't do that, and this might be the last picture I have with him together back from a number of years ago. I love that guy. And I am so fortunate to have been asked to be a speaker in his honor today. Thank you all very, very much.
I want to thank you that and for sharing your journey. And I love this idea of what are you going to do? How are you going to respond? And part of what I hear in what you're saying is it's something you're still asking. What am I going to do? And how am I going to respond? It doesn't end. I want to open this up for any questions or comments.
Yes, sir.
First of all, amazing. I will stand up. It was an amazing talk, so thank you so much for your time today. Dennis Spencer, one of the gastroenterologists at Children's Hospital. I work in office. Oh, there we go. Great. And I'm also in student affairs here at the medical school. I'm curious because you had the kind of list of things that the future individuals in this room will hopefully be able to lead in. I'm curious, how do you propose people get the exposure to be able to maybe go into government or take on some of these like C-suite positions that in 2046 some of us may take? There are, the thoughts of going to get an MBA or, the MPHs and things, but I don't know if there's any advice that you give people maybe in the pipeline for experiences, exposures to seek. How do they get the mentorship?
Can you imagine what it was like to be Harriet Tubman?
Oh, I cannot really imagine.
Can you imagine the crap that that your great grandmother went through? My last name is Myers, M-Y-E-R-S. It's not a Nigerian name. It's not a Ghanaian name. It's Joseph B. Myers was the slave owner in Bullitt County, Kentucky. The slave quarters were behind the house where he regularly raped my great-great-grandmother. And then a whole line of Myerses came after that. Can you imagine the courage that it took for that family, including my great-great-grandfather, who knew this was happening, and to live their lives and then escape Kentucky, right across the border, the Ohio River is Indiana, and Indiana wasn't a slave state mostly, although southern Indiana was kind of a slave state. And then in the 1920s to leave Kentucky permanently to come to Indianapolis and try to make a new life. That's courage. Deciding to get an MBA or not, that ain't courage. That's just logistics and timing and funding and there are variables that you need to manage. It takes courage to make a decision to change shit. I'm sorry if I've offended somebody with my language, but that's what it takes courage to fix big problems. You have been given a tremendous opportunity by being in this institution. You've been given license to fix big problems. So get the information needed in order to decide whether you get your MBA. I've given this advice earlier today. It can be very helpful. It's not a rarity like it used to be. I was the second MBA at Stanford Business School. They have 4 or 5 per class nowadays. And there are a lot of, Northwestern has a program that gets you your MBA if it's a physician. A lot of the MBA schools have seen this as an opportunity to educate physicians that want to fix healthcare. And if one of those programs fits and you can get in and you want to do the work and you want to get the degree, I think it's great, especially early in your career. The earlier you get all your alphabets behind you, I think, the better off you're going to be. Then you can actually use them and get to work. So I would urge you to take a look at the best opportunities and then ask people that did that program. What did you get out of it? Would you do it again? You find 3 or 4 graduates of the program you're interested in and call them up and they'll talk to you. Would you do it again? Or how would you do it differently? And you'll get an answer, either about doing it at all or about that program. By the way, you're a gastroenterologist. I didn't mean to diss colonoscopies.
There are plenty of them to be done.
You have an unlimited number that you guys could do. So, and I don't believe in Cologuard, by the way. The false positives.
Say it louder.
Cologuard. Forgiveness to Exact Sciences. I do not own any stock, but please forgive me for my comment on colonoscopies. But that's how I don't know if I've answered your question or not, but you got to judge it.
No, it's great. I mean, truly, there are students that when you're advising people, how do you guide them? Because they're looking for,
right,
in some cases, very specific instructions. I believe in the idea of it takes courage, and that if this was easy, everybody would be doing it.
Bingo.
So you have to actually
ding,
put your
ding,
foot
ding,
forward
ding.
and do it.
Yeah.
But, I was wondering what has worked for you when you give this advice, because I'm often saying what I would do as Dennis Spencer.
Yeah.
I'd love to hear what other people have to say.
I ask the person a few questions. I kind of get and then by doing that, I got to get a sense of whether it's just a notion or is it something that they truly consider. I did all the required courses at Harvard Medical School. I got my best grade in psychiatry, which I still don't understand to this day. But I had some ability, I guess they said when they wrote that little paragraph in, to have insight into people. And it served me well in all the things that I have done. I've been able relatively quickly to kind of get a sense of where somebody is coming from and then dig in a little bit and then make some decisions that are often correct, not all the time. But you got to know your personality. That's why I put that crazy Myers-Briggs card up there. You got to know who you are. You're an introvert, an extrovert, or this or that, and then figure out where do I best fit, and then do what you think is best.
Thank you.
You're welcome.
Thank you.
So I have a question I'm very appreciative for, Elnora, and I'm a critical care nurse and I'm an MPH student at Chan. I have a question about practicality for boots on the grounds workers. I have an appreciation for a lot of the upstream roles that you've spoken to this room and said you could achieve all of these things, but what about the workers in healthcare systems that don't want to be in the C-suite and they're content with being on the ground, but they're not content with the injustices that they're seeing? How do we speak to those people? How do we innovate from the ground up? What are the solutions that we're bringing to the front lines?
Why don't you lead them?
And I get that, right?
You become the next chairperson of the California Board of Nursing or the New York Nursing License Board or the nursing of union that serves New York City Health and Hospitals Corporation. There are plenty of leadership roles of those people, for those people. And you've already got the credential by having been at Chan of doing something out extraordinary. Use it to lead the people you care about.
And I have an appreciation for that answer, but if I'm going to the healthcare systems, if I'm going to the ICU and I'm speaking to nurses on the ground or speaking to nurse practitioners on the ground, how do I, like, what are things that I can do practically? Because that seems like, oh, in a couple years you can get that position, right?
I didn't say a couple years. I think it's going to take you some time and some effort and some energy and some dedication to get there, but you can get there. Okay. If not you, who? If not now, when? I mean, come on. You're at Chan. You're not out there, right? You're not on a 12 to 6, right? You're not doing 2 12s or 3 12s or 4 10s for your nursing shifts. You are at Chan, the #1 or maybe #2, depending on how you rank them. School of Public Health in the United States of America. Come on. I'm telling you, I'm encouraging you. You've got to see yourself as who you're a leader. You wouldn't be sitting here if you weren't interested in leadership in some way. So figure out how you translate the interest in leadership to becoming the leader that you know you want to be. You're welcome. Thank you. Yes, ma'am.
Thank you so much for your lecture. It was very insightful, especially for me as, yes, I have to do that. My name is Danielle Keondo. I'm a senior in high school right now, aspiring to pursue medicine. So I just wanted some advice as to how you would, as like, we're thinking about like what we want to do in college and stuff like that. Like, what would you advise in terms of like, any classes, maybe like a minor that we should take? Because you did mention politics, which is a perspective I've never heard, because I feel like when we think about making change in medicine, it's like, oh, I'm gonna get my degree and then I'm gonna practice and I'm gonna do all these things. So that was a very different perspective. So would you like, what would you suggest as like, we're entering college and university in terms of like our majors and our minors and just organizations that we can join as students to try to help out with fixing inequality in healthcare?
First of all, thank you for being here. I did not expect to see a big audience of high school seniors. And thank you for your interest in trying to fix these problems. That's step one, wanting to do something. And you've already done step one. Step two, you got to get into the best college you can. Step three, you got to do as well as you can once you get in. The major you choose is less important, I think, today than perhaps it was in the past. In the old days, somebody would have said biology, chemistry, or physics, something in the hard sciences. There's nothing wrong with that. And a lot of schools still prefer that. But there has been a change in thinking in many university medical schools about whether you need that or not. And a lot of them are kind of opening up the doors a little bit more towards liberal arts majors and other kinds of majors. So I think that's likely to continue to evolve. I think the most important thing is to something that you're good at and you like, and to do really well in that. And so if you pick a liberal arts major, then maybe you minor in one of the sciences or vice versa. So that's one way to think about it. There'll be a lot of pre-med advisors at whatever college they'll tell you a lot of different things. Forget half of the things that they tell you. Because if those, I mean, many of them are telling you what they say in the book of how to advise. They haven't done it themselves. If you ever meet somebody on an admissions committee that's for medical school, they're the ones that you want to ask. Or ask the medical students who were successful in getting in that took a major that wasn't normal or wasn't traditional, like somebody who majored in philosophy or something like that. If you meet one of those folks, they're the ones that you should ask, how did you do that? But I think it's much more important to do well in what you choose than which one you choose.
Thank you so much.
Welcome.
We have 2 more right here, and then we're gonna move to the next part. Barbara.
Thanks. My name is Barbara Sweeney. I worked with Dr. Poussaint, so I have a special interest in your work. I had a question given the current kind of changes in the climate of research that you mentioned not being able to find data, current data about how many Black students applied to medical school and how many got in. And so much seems to be pushing to not have that data available or don't do research using those metrics. And then how do you address inequality if you can't figure out where the inequality lies? Like you can kind of intuitively know, but how do you document it and address it if you can't do that research?
The AAMC actually has a pretty good database on the number who apply and how many get in. And they do a very good job of telling you on race and gender in big numbers. And they give you a little bit, just a tiny amount of information about people, the application numbers and rates and MCAT scores, et cetera, at institutions. But they have scrubbed their data so clean of what did Harvard do versus Yale. There is nowhere you can find that I was able to find to get that. And of course they have it. But they've made a decision to take that out of easy reach. Probably for defensive reasons, probably for some one of their lawyers has advised them it's easier, cleaner, at least for the next 3 years, to take that out rather than put it in. And they've done a pretty good job of scrubbing it because I'm a pretty good sleuth and I could not find it. But it exists, it's there. You know, somebody knows exactly the right number. I could probably have done a little bit more work to ask the right person the number and maybe have found it, but I don't get the sense that it's any different. I think that the rate of acceptance today is lower than it was 2 years ago and probably equal to what it was when I was coming through. I think those are two pretty good assumptions, and that's a backward trend, and I don't like it. It implies, you know, that let's say it's 50% of what it was 2 or 3 years ago. It implies that 50% of the people that we let in 2 or 3 years ago were a mistake. And why the admissions committees and the leaders of the deans don't understand that is a mystery to me. What does it say about your decision making? You know, Alvin Poussaint said famously when, well, are the slides still available or are they done? Never. Alvin Poussaint said famously that if Harvard's degree, we were under attack by a professor of microbiology named Bernie Davis. He had written an article in Sounding Board at the New England Journal of Medicine in 1986, basically equating Black students at Harvard Medical School to pilots who flunk landing. Read it. I'm not making this shit up. But Alvin was a tiger. Man, he came out and, you know, my little speech was milquetoast compared to he was terrific. He came out and he told the truth. And he said if Harvard made a mistake about giving degrees to Black students, that it made a mistake about giving everybody's degree. And Harvard should be taken off the map or something like that. I mean, it was like, and it was truthful. It was like, if the faculty decided you deserved an MD, isn't that what the faculty is supposed to do? And then to imply that the faculty, oops, we screwed up for 20 years, and now we've got it right because somebody somewhere decided to take the money. I guarantee you that if it wasn't the dollars, these threats would not have been responded to the way they were. If it wasn't the ability to take the money, that's what's freaked everybody out, the ability to take the cash. And that was what was so successful about the architects of Project 2025 when they figured this out. You don't just tell them to get rid of DEI, you take the money away. And you don't just take the DEI money, you take all the money. And then you make them fight to get it back. And they spend all their time fighting to get the money back. And they forget about DEI. Because the money that they're fighting to get back is not the DEI money, it's all the other stuff. It's that indirect cost dollars. It's those indirect cost dollars. And for those of you who have no idea what I'm talking about, indirect costs, academic medical centers, Google it. You will learn a great deal about how the world really works and the dollars that come to institutions like a Harvard and a Stanford in the form of indirect costs. So I think that a lot of things are at play here, and what we should be doing is I think we got to fight the battles that are here today, but we should be getting ready for the new battles that we're going to have 3 years from now. Because there are going to be those that are arguing, hey, it's okay, nobody screamed about it. Let's just leave it where it is. That's what I'm afraid of. So you got to be ready 3 years from now and say, no, we want it better than before, and here's why. Did anybody read the studies that show about concordance? Did anybody look at the studies of the number of physicians we import from other countries to take care of Americans? It's stealing some of the best brains from other places to come here. Did anybody report, on that? I think there are a lot of ways to think about where we are today. And one of those ways is to get ready for what happens in 3 years. Because I think it will be different. Is that it? Was there one more?
One more and brief.
Hi, everyone. Hi, everyone. My name is Catherine, and I'm not a medical student, but I have gotten my MHA from the MGH Institute of Health Professionals, and I actually was a philosophy major. So when you mentioned it earlier, it was definitely funny. But I'm interested in how you would recommend somebody like myself that's on the peripheral of healthcare to advocate for some of the challenges that I see with AI as a social determinant of health. I've taken the alternative route to go the grassroots level, and I'm on some review boards, and we talk about the importance of critical thinking and how that kind of applies to education, but also the qualities of life with our resources draining due to AI. And as someone that's on the analog world and the digital world, and how you've seen a lot of these types of things go, how do you recommend setting up changes that would impact future health outcomes for minority groups, especially in rooms where the validity that we're building online isn't as valid as if it was backed by an institution like this one?
Asking a question like that proves to me that you don't need my help. You're already on your way. You've framed the question in a logical, thoughtful way. You just need to keep doing more of what you're doing and learn how to use your voice. You have a voice. You have a knowledge base. Where is it best applied? You're going to have a lot of opportunities to do things. Your problem is going to be deciding what things not to do versus the things to do. And that'll be your challenge. It'll be your challenge, by the way, your whole career. It doesn't go away once you get a degree. You can make a difference with an MHA, with an RN, with the B, that in a lot of different ways. You got to find a lane that works for you. And then you have to fight. And you have to fight in a way that makes logical sense for you and your life and your family and all the things that you want to accomplish. And I gave you like a dozen different ways to fight. There's not just one way. You don't have to do politics. There's like a million ways to go about it. So just keep doing what you're doing. And when those opportunities come, grab them and execute. Do the right thing. Make sure that you are excellent when you get the opportunity to move forward on something that you know will count. But learn to use your voice. All right. And I'm not trying to embarrass you or anything, but the next time you ask a question, you stand up. You project. You ask it with confidence. I mean, you want everyone to listen and hear what you have to say. All right. And so there are a lot of techniques for that. And I think the more effective you are in using them, the more effective you are going to be in having people, wow, what did she say? Who is that? That's the reaction that you want people to have. We got to get her involved in X, Y. That's how it happens. And there are lots and lots and lots and lots and lots of ways for you to make a huge difference. So use your voice, learn how to project it, learn how, and make sure that people get a sense of that. You've got to care about people and their problems. They have to feel that. People have to know that you come from a place of empathy and with a knowledge base. And that's the last thing I'll say. Joan's trying to. Every speech I give, it ends with or begins with the Wizard of Oz. Everyone. You got to have the brains. You got to have what Scarecrow had, right? You got to have a heart. You got to have empathy. You got to know what you're talking about. But the lion was the one who made the difference. You got to have courage. It's the courage variable. That's where a lot of people falter. They don't have the courage to follow through and take a risk and do something that somebody has said, oh my God, you can't do that. That makes no. For you, it could make perfect sense if you've thought it through and you have the courage to execute. So congratulations, you're halfway there.
Thank you.
You're welcome.
Thank you. Thank you. So I want to thank you for all that you have done and your willingness to step into so many different places at different points in times, to speak up when someone needed to speak up. But here today, thank you for understanding the importance of those who will follow, and the voices and the dreams and the hopes and the desire to make a difference, and of encouraging the future. And with that, I want to give you this. This is the Alvin
Oh, wow.
Poussaint lecture. And I'll ask you to come up here at the same time. Yeah, but we'll take a picture. Let me take a picture and take your remarks.
Can we have a better background? You have a different background.
Where you want it?
He wants a different, he doesn't want the curtain.
Yeah, I don't want to. Just right here.
We can do a background that has Hinton.
Yes.
Okay.
Oh, perfect, perfect.
Myers and Heavy. Hold it at the very top so I see as much of the award as I can. So put your right hand on the top. And I'll shift that a little bit over to your left.
You're practicing, so when you get your award. That's what you're watching for. That's what you're watching for.
There'll be 2 more shots. Good last one.
Thank you very much for this. Very nice. Thank you.
I'm going to ask Dr. Tina Poussaint to say a few words. She herself is a giant here in the medical school in what she has done and what she has accomplished.
Well, good afternoon, everyone. Alvin took great pride in the establishment of this lectureship here at Harvard Medical School, envisioning it as a forum to bring forward the brightest and most impactful physicians in the world, individuals whose work would shape the future of medicine and humanity. Dr. Woody Myers, thank you for your exceptional and inspiring lecture today. Alvin spoke of you often with admiration and deep confidence, having mentored you from your time as a medical student and throughout your career. He recognized early on the remarkable trajectory you would follow and the profound impact you would have in our field and on the world. It is truly meaningful to see his vision realized. Alvin was a man of unwavering integrity and courage. He stood firmly for excellence, equality, and justice, not only in words, but through action. From providing care to civil rights workers during the Selma and Meredith marches, alongside Dr. Martin Luther King, to his enduring commitment at Harvard Medical School in recruiting, advising, and supporting generations of outstanding medical students, his influence has been far-reaching and transformative. His advocacy for mental health, particularly for children and families, remains a lasting and essential part of his legacy. Joan, thank you for your steadfast dedication to preserving and advancing his legacy and its enduring commitment to justice. Thank you all for ensuring that Alvin's legacy remains vibrant and enduring, never forgotten, especially in a time when his values are needed more than ever. It is a legacy that not only inspires reflection, but calls each of us to action, serving as a guiding light for the wonderful principles that he lived by so fully. So thank you.
Thank you. Can the two of you take a picture together, please? Without me, two of you, please. Thank you for being with us today. As they're taking this picture, I also want to extend my appreciation to the Alvin Poussaint Visiting Lecture Fund Advisory Committee, the Office of Student Affairs, to Barbara and Harpreet and Dr. Andrea Reed, to HMS Media Services, and to the members of my Office for Culture and Community Engagement for today. What you'll see as you came in, there are many upcoming events, a conversation around entrepreneurship on March 31st, the Howard Dorsey Still Lecture. Howard Dorsey and Still were the first 3 Blacks to graduate from Harvard Medical School on April 9th. That will be talking about pluralism. An opening doors conversation with Fred Lovejoy on April 14th, and another program on April 15th with Rob Langer. Thank you for being here. Woody, thank you for coming here today. I know that there's been a lot going on for you. He just laughs, you know there's a lot. But this was important. And he actually made all his arrangements around being here today because of how important this is. There are many of our community who remember and love Alvin. And thank you for being here. Tina, thank you for being here today and saying those words. It means a lot. And for all of you who stood up and asked how and why and when, I agree with Dr. Myers. We're looking to you for those answers. You are our future. Absolutely are our future. Thank you very much for being here.